every single gene therapy trial for hemophilia has so far only enrolled adult patients. So, which is nice, but I think it would be nice that we could also enroll children. And there's a good reason why children have not been enrolled in any of the trials is because liver in children up until age 10 to 12, the liver is still growing and dividing. Those hepatocytes are still dividing. And because AAV genome remains episomal, which means when the cell divides, it gets diluted out. So by delivering AAV vectors to the liver in children is probably not going to work, because every cell division, the genome will be diluted out and you will lose the therapeutic benefits of doing gene therapy. So something needs to be done, because children obviously need gene therapy just as much as adults do for hemophilia. So the idea that we actually based this on was developed almost 30 years ago. So instead of using AAV inverted terminal repeat, which is a single-stranded, although most of it forms a double-stranded hairpin structure, we actually ligated the complete hairpin molecule at the ends of the genome. So now this is a one continuous molecule, and hence we call it the Noend DNA. So it has no free ends. It just continues on and then becomes a double-stranded DNA. And we recently showed that this molecule is biologically active and also can be retained by the cell much longer, because those close ends provide protection from degradation. So this genome can actually last in the cell much longer. And although it's not there in the abstract, we also have our collaborators who have generated synthetic liposomes. So the idea is to put this Noend DNA carrying a therapeutic gene. In this case, obviously it's going to be factor 9 gene for hemophilia B and factor 8 gene for hemophilia A, and then simply inject this synthetic vector into the peripheral vein, and hopefully it will target the liver without causing an immune response, express the gene, and then even if it gets degraded eventually, which I'm hoping at least it will last for at least 6 months or so. Remember, currently patients have to be infused with the clotting factors twice or at least once a week. So this would actually significantly improve the quality of life by if you have to inject this into patients only once in 6 months. So, of course, the other advantage is that unlike AAV, you inject once and immediately the host immune system will react to it, and body will make antibodies to AAV. So you cannot do, at least currently is not possible, to do the second dose of AAV injections. Whereas with the synthetic AAV vectors, we hope that we may be able to do this repeated delivery. And in mouse models, our collaborators have shown that, yes, it is possible to deliver this repeatedly, and you can maintain the transgene expression. So again, our hope is that we can develop these synthetic vectors carrying either factor 8 or factor 9 gene for hemophilia B and A respectively, or actually it could be used for any human liver disease, which is currently impossible to target with the best AAV serotype vectors in children, because as I said before, because of the dividing nature of the liver, the AAV vectors will be lost.